This is a presentation on chronic kidney disease. We'll be focusing on clinical manifestations and what to look for in our patients with CKD. So as the name suggests, chronic kidney disease, or CKD, is a slower and more progressive disease when we compare it to something like AKI or acute kidney injury. And it can take years of stress and damage to the kidney for someone to progress to chronic kidney disease. And unfortunately, chronic kidney disease is irreversible. So the treatment a patient receives for CKD will be for the rest of their lives unless they receive a kidney transplant. And you can see here some of the most common risk factors as well as how we can prevent and manage those risk factors. Notice that there are notable health disparities related to CKD in that ethnic minorities are more at risk as well as individuals with some of the most common diseases in the United States, such as diabetes and hypertension. Now, something else we should keep in mind is that a person with CKD can be in different stages of the disease. So you can see here that patients are classified by glomerular filtration rate, or GFR. And we like a high rate of filtration in the kidneys, right? Higher GFRs signify better renal function. So as a patient progresses from stage 1 to stage 2, 3A, 3B, 4, and then ultimately to stage 5, their GFR is dropping. The damage to the kidney is worsening. And how the patient is treated goes from maybe risk reduction to more aggressive treatments such as dialysis. The patient with CKD has a number of possible clinical manifestations, and you can see from this illustration here that CKD affects virtually every system in the body. And what we're going to do in this presentation is discuss why patients might experience specific clinical manifestations by linking them to what the kidneys should normally do. And by doing this, it will hopefully be less intimidating to memorize all of the problems in a patient with CKD. So this looks like a bit much, but here we have a table that essentially shows in the left column all of the normal functions of the kidneys. The details of this are discussed in a prior video, so if you need to review, I recommend watching that video. But as we look at this list of what the kidneys should normally secrete, what they should normally synthesize, and what they should normally excrete, we can already start to imagine what would happen if the kidneys were damaged or failing and could no longer do some of these things. Looking at what the kidneys normally secrete, what would happen if a failing kidney could no longer secrete sufficient erythropoietin? Now, because erythropoietin normally stimulates red blood cell production, a patient with CKD could develop anemia. Just keep in mind, we may also see anemia for other reasons, such as iron deficiency, hemolysis, and red blood cell loss that can happen during dialysis. Now, regarding renin secretion, this occurs when hypoperfusion to the kidneys is detected. This can lead to sodium imbalance. If the kidneys are hypoperfused, then renin may be secreted, which triggers the RAS system, or the renin-angiotensin-aldosterone system. And it can be activated, causing sodium and water retention, putting our patient at risk for hypernatremia. From here, we may see hypervolemia and therefore possible hypertension. Now, just keep in mind, as we retain fluid and our sodium gets diluted, sodium levels may normalize or even drop. The kidneys are also responsible for synthesizing calcitriol. If the deteriorating kidney is unable to synthesize sufficient calcitriol, which remember is that activated vitamin D that helps us absorb dietary calcium, then we're going to see hypocalcemia in our CKD patient. But it doesn't stop there. And this is actually a somewhat complex chain of events. So, low calcitriol leads to less absorption of dietary calcium, which leads to hypocalcemia. This hypocalcemia then triggers the parathyroid gland to secrete parathyroid hormone. Now, why? Well, parathyroid hormone actually stimulates bone demineralization. So essentially, parathyroid hormone says, I see you're low on calcium. I know where we have some extra calcium stored. It's in the bones. So parathyroid hormone triggers a release of calcium from the bones into the bloodstream in an effort to fix this hypocalcemia problem. Now, unfortunately, as you can imagine, this is not going to go without problems. As calcium is released from the bones and into the bloodstream, phosphorus is also released. And one thing that happens in CKD is that the kidneys are actually not able to excrete all of this extra phosphorus. So now we have too much phosphorus floating around in the blood. And this is a problem because that phosphorus really likes to bind to free calcium. So we've just created a new problem. We freed up calcium from the bones, but that free calcium is now just binding to the phosphorus that was also released. So we still have hypocalcemia, low free calcium floating around in the blood. And now we have all of this calcium phosphate floating around, leading to calcifications, where we see this calcium phosphate being deposited in really important places like the blood vessels, the eyes, and even in the heart. So this is a lot to take in, but essentially our patients with CKD can have hypocalcemia due to poor dietary absorption that can lead to bone demineralization and calcifications. Now, one of the other key things our kidneys do is get rid of urea and nitrogenous wastes. So in our patients with CKD, they can progress to the point of something called uremia, or urea in the blood. And put simply, since urine is not leaving effectively, it's now floating around in the bloodstream. And where does our blood go? Everywhere. So in the case of uremia, that urea can affect multiple body systems because the blood is going everywhere. Now, depending upon the stage of CKD our patient is in, we may see different manifestations of urea and other waste products irritating specific systems. But taking a look at this list, it can irritate the pericardium of the heart, so that's referred to as uremic pericarditis. It can irritate the pleura of the lungs, called uremic pleuritis. In rare and severe cases of CKD, urea can irritate the skin, and this is called uremic frost, where urea actually crystallizes on the skin and can cause a lot of really bad itching. As you can imagine, urea also irritates the neurologic system, so urea and other nitrogenous waste products can cause CNS depression, lethargy, irritability, anxiety, and a lot of other symptoms. And as urea irritates the peripheral nerves, it can cause uremic neuropathy, where patients feel paresthesias in their feet and their legs, and they may even have motor function issues. Now, urea can even be smelled on the breath, and this is called uremic fetor, where a patient's breath actually smells a little bit like urine. And as you can imagine, this and other factors can lead to a depressed appetite to the point of anorexia or even cause nausea and vomiting. And because of how urea can alter white blood cell function, we may see an altered immune response, and our patients with CKD are now at an increased risk for infection. And last, we might see platelet dysfunction, where platelet aggregation is impaired. So our patients would be at an increased risk for bleeding. And keep in mind, as we discussed previously, our patient is already at risk for anemia as well. Looking at how the kidneys should have excreted ammonia, this buildup of ammonia in our CKD patients can further affect their neurological system with an increased risk for encephalopathy. And because our kidneys were supposed to excrete hydrogen ion, that hydrogen ion is now building up in the bloodstream in our CKD patient. More hydrogen ion means more acid, so we will see increased risk for metabolic acidosis. And because the kidneys normally remove up to about 90% of our excess potassium, hyperkalemia can occur in our CKD patients. And this is a big concern because hyperkalemia can put our patients at increased risk for cardiac dysrhythmias. Now next, as you think about all of the drugs you learned about in nursing school, many of them rely on the kidneys for metabolism or excretion. So without properly functioning kidneys, these drug levels can build up in the blood. And with higher drug levels, we can see stronger and more prolonged effects of those specific drugs. Looking at more substances the kidneys were responsible for excreting, we have excess insulin, excess magnesium, and excess phosphorus in our patients with CKD. When excess insulin is not excreted, our patients will have higher levels of circulating insulin in the blood. So this results in a hyperinsulinemia. Having extra insulin circulating in our blood is not a good thing. If our patients already had diabetes, which remember was one of our risk factors for CKD, then if they are already prescribed exogenous insulin, this increase in circulating insulin is going to affect their dosing, often leading to a decreased dose and very, very careful monitoring of their blood glucose. Now, another thing that happens when there's too much circulating insulin is that it eventually can cause insulin resistance, which stimulates our livers to produce triglycerides, leading to dyslipidemia. And as you may recall, the number one cause of death for our patients with CKD is cardiovascular disease. So you can see how this dyslipidemia can play a role there. Now, the kidneys aren't excreting excess magnesium either, and we may see a slight increase in serum magnesium, but this is usually only an issue if patients ingest excess magnesium, so taking drugs like milk of magnesia or antacids with magnesium. And then last here, as discussed before, excess phosphorus is now circulating because our kidneys are not effectively excreting it. And so it's also being pulled out of our bones due to parathyroid hormone. So this phosphorus is also binding to calcium, causing calcifications in various places like the heart and the eyes. Now, just like when we talked about urea building up and irritating multiple body systems, fluid overload creates a number of problems as well. Our kidneys excrete the extra fluid we didn't need, and in the case of CKD, especially as it advances, that excess fluid is not getting excreted, and our patients can develop hypervolemia. However, early on in CKD, we will not often see this. We won't even see oliguria. In some cases, especially those with diabetes, we might even see polyuria early on. But as CKD progresses, urine output will start to drop, and eventually to the point of oliguria, which is less than 400 cc's a day, to anuria, which is typically considered less than 40 cc's a day. So ultimately, with this hypervolemia problem, we will see hypertension, which puts more stress on that left ventricle of the heart, now having to pump against a higher pressure. So at first, that left ventricle might get bigger and hypertrophied, but then it could lead to possible heart failure or CHF. This hypertension can affect the patient's eyes, causing hypertensive retinopathy, and hypervolemia can obviously affect our lungs, leading to pleural effusion, pulmonary edema, and putting our patients at risk for pulmonary infections like pneumonia. This excess fluid can begin to build up in our peripheral tissues as well, causing peripheral edema to the extremities, causing risk for impaired skin integrity. Also, having too much fluid can begin to dilute some laboratory values, specifically sodium. So while the total amount of sodium may not change, increasing the amount of fluid in the bloodstream can create what's called dilutional hyponatremia. Just keep in mind, if the RAS system is triggered, that can increase sodium retention, which can cause more fluctuation in our sodium levels.